There are exactly 12 ways the ADC can fool you, not 50, not 100, 12. Every wrong option in every scenario you will ever see belongs to one of these 12 categories. You have just read them all with a word example for each one. What I want to do now is show you the pattern underneath all 12, because once you see it, you cannot unsee it. And then I want to tell you which 3 traps you are statistically most likely to fall into, because they are the 3 that look the most correct to a clinician trained outside Australia. Every trap in the taxonomy has the same underlying structure. The wrong option is what a well-trained, clinically experienced international dentist would do. The correct option is what the minimally competent recent Australian dental graduate is expected to do. Those 2 things are sometimes the same. When they are the same, the question is straightforward, but when they are different, that is where every trap lives. An experienced international dentist stops warfarin before an extraction. The Australian standard says check the INR first. If it is within therapeutic range, you do not stop it. The experience that should help you is the experience that gets you wrong. An experienced international dentist prescribes amoxicillin for a periapical abscess because that is what the evidence base in their country supports. The Australian standard per TG September 2025 says no systemic failure, no antibiotics, drainage, pulp treatment, extraction and analgesia. That is that. The trap is not ignorance. The trap is confidence based on the experience that does not match the Australian standard. That is the pattern. Every trap in this taxonomy is a version of that pattern. Scene 3. These traps generate the majority of errors in this trial exam. They are not the most clinically complex. They are the most common because they each hit a different habit that is deeply embedded from international training. The most common, antimicrobial stewardship. A patient has irreversible pulpitis and acute periapical periodontitis. They are in significant pain, no swelling, no fever, no trismus, no lymphadenopathy. The habit says infection, antibiotics. That habit is wrong in Australia. TG September 2025 is explicit. Antibiotics are not indicated for pulpal or periapical pathology without systemic features. The correct management is drainage, pulp treatment or extraction, and analgesia for pain. The exam will give you a patient in pain and it will give you amoxicillin as option 1. That option will not correct. That option will look correct. It will feel responsible. It will be wrong. No systemic features, no antibiotics. Every time. That is not a guideline to remember. It is the Australian standard you are being tested on. The second most common is outdated guideline. TG September 2025 introduced 15 significant updates. The most tested is the analgesic ladder. The new first line recommendation for post-operative dental pain in a healthy adult is paracetamol, 1 gram every 6 hours, alternating with ibuprofen, 400 milligram every 8 hours. The exam will give you a patient with a post-operative pain. It will give you ibuprofen alone as one option and paracetamol alone as another. Both were acceptable under previous editions. A candidate revising from the previous TG edition will select one of those. They will be confident and they will be wrong. The exam is built against TG September 2025. If your revision materials are built against anything else or against nothing Australian at all, you will fail the questions that test these updates. That is not a possibility, it is a certainty. The third most common is autonomy misapplication. A patient asks for extraction rather than root canal treatment, or they refuse a recommended procedure, or they request something that is not in their clinical best interest. The trap option says, agree immediately. It is the patient's choice. The habit says, respect autonomy. The trap is that genuine autonomy requires information first. A patient cannot make an autonomous decision without understanding the clinical consequences, what they are asking for. The correct answer is always the same sequence: acknowledge the request, provide the clinical information, consequences, alternatives, sequencing, confirm understanding, then accept the decision. Agreeing without information is not autonomy. It is passive compliance. The exam will test whether you know the difference. Question 5 of every scenario tests this cluster. The question behind question 5 is always the same. Did the clinician give the patient enough information to make a genuinely informed decision? Or you have read all 12. Let me give you one line version of each remaining one so the names are active in your memory. Trap 4 is 𝗪𝗿𝗶 violation. The OPG is almost always wrong when a targeted view answers the clinical question. Ask what specific question you are answering and what is the minimum view that answers it. Trap 5 is anchoring. You see the word warfarin and you stop reading. Read the INR value. The qualifying detail in the scenario resolves the question. Do not stop at the headline word. Trap 6 is premature closure. The first plausible option is not always the correct one. Apply the Australian benchmark before selecting. A response can be clinically reasonable and still fail the Australian standard. Trap 7 is drug class confusion. MAO inhibitor interactions are not SSRI interactions. Beta blocker interactions are not calcium channel blocker interactions. The drug name matters, not the drug class you think it belongs to. Trap 8. Scope creep. Antidepressant management is the GP's scope. Anticoagulation management is a specialist's scope. A correct clinical statement about someone else's medication is still scope creep if it's substitute for a referral. Trap 9 is over-referral. Well-controlled hypertension on amlodipine is not a reason to refer to a hospital dental clinic. Know your scope. The exam tests whether you know what belongs in GP dental practice. Trap 10. Open disclosure sequence. The sequence is acknowledge, apologize, explain, document. It is triggered at the moment of discovery, not after the procedure, not after, not via the practice manager, and not only when harm has occurred. Trap 11. Informed consent gap. The patient requested it and signed a form. That is not informed consent. The patient must have received and understood material information before the decision counts. Trap 12. IPC breach response. A torn sterilization pouch means the instrument is unsterile. You stop immediately, replace it, inform the patient and document. There is no acceptable threshold of tear size. You now have the complete taxonomy, 12 categories, one pattern underneath all 12. The wrong option is what a well-trained international clinician would do. The correct option is what the Australian standard requires. From this point in your preparation, every question you read, you should trigger a taxonomy check. Not just what is the answer, but which trap is this question built around. When you can name the trap, you can see the wrong option for what it is. It stops looking correct. Season 7 takes 4 of the highest frequency trap categories and show you exactly how they appear as live clinical decision in Australian scenario. AHPRA open disclosure, PG September 2025, 𝗪𝗿𝗶 radiograph justification, ADA IPC 2022. Each one has a 2-minute case, each one showing exactly how the exam tests it. Not as a rule to recall, but as a decision you have to make inside a scenario. Go to session 7 when you are ready.